So I'm going to read this article called Fat Cell Turnover in Humans. The authors are Peter Arner and Christy L. Spalding. It's from May 2010 in the journal Biochemical and Biophysical Research Communications. The reason why I'm doing this is I'm a molecular neuroscientist, and there's a lot of talk about fat cells being the only fat cells you have, kind of like neurons, which is just not true. But recently, glitterandlazers, Anna O'Brien has had some cutting off of fat tissue without losing the weight first. And the question is, what's going to happen to her body? And I was curious about that too, so I started reading on just fat cells. And lipidemia is very circular logic. If you overeat, your body finds a way to store it. The fact that there are going to be fat cells that are abnormal compared to someone of a more standard weight it's just circular reasoning, and it's very annoying. So anyways, let's read this. Fat cell turnover in humans. I have 2 articles I pulled up that I wanted to read for myself, and I figured I might as well record them. Abstract: obesity is a condition where excess body fat accumulates to such an extent that one's health may be affected. Owing to the cardiovascular and metabolic disorders associated with obesity and the epidemic of obesity facing most countries today, life expectancy in the developed world may start to decrease for the first time in recent history. Other conditions such as anorexia nervosa and cachexia are characterized by subnormal levels of adipose tissue and, as with obesity, lead to morbidity and mortality. Given the significant personal and economic costs of these conditions and their increasing prevalence in society, understanding the factors that determine the fat mass is therefore of prime interest and may lead to effective treatments and/or interventions for these disorders. Fat mass can be regulated in 2 ways. The lipid filling of pre-existing fat cells could be altered, and the number of fat cells can be changed by generation of new fat cells or the dying of old ones, i.e. adipocyte turnover. This review summarizes what is known about fat cell turnover in humans and the potential clinical implications. So it seems in videos a lot of reacting to fat acceptance, anti-fat acceptance, and creators who quote-unquote are living in larger bodies. Asinine way of stating that, but in the reaction community, it seems that a lot of people think that fat cells are like neurons, and what you have from birth is what you have throughout your life, which just biologically doesn't make sense. So this article is on generation of new fat cells and when that would happen, which might be at a very low rate for someone of normal size, but the article will tell us. So adipocyte, it's just adipocyte. Oh, my speaker's not on. Let's see how the gentry pronounce this. I think I might have a speaker on this one. Nope, I do not. Nope. Well, I don't know why the speaker isn't speaking. Mute's off and stuff. No headphones. Well, anyways, it says adipocyte. Adipocyte. That's what I was saying, right? Anyway. adipocyte. Adipocyte. Whilst so number 1, adipocyte turnover. Whilst homeostatic mechanisms within the body work to keep the energy balance close to zero, a positive energy balance results in an increase in energy storage in cells in the form of fat, triglyceride, in parentheses. Similarly, a negative energy balance results in a decrease in fat storage and decreased fat cell adipocyte volume, meaning the cells are not as large, not the number of cells decrease. Despite daily fluctuations in the energy balance, humans manage to keep the fat mass remarkably constant throughout adult life. If, however, changes in the energy balance occur over time, then a net change in the corresponding fat mass occurs. So that would be like consistently overeating or undereating, but I think more regular occurrence would be just implementing using the energy that you eat. So a change to physical activity. Many studies have shown that significant weight loss in humans, corresponding to a significant loss of fat tissue mass over months or years, results in a decrease in the volume of adipocytes, but no decrease in adipocyte number. So that's probably where a lot of the... I wish I could read this in a different voice so you could know when I'm speaking and when I'm reading. But that's probably where a lot of the confusion comes in. Over whether there's a static adipocyte number. If you start losing weight, those cells do just shrink. And if you start gaining weight, the first thing to happen is going to be they're going to get bigger. Back to the article. Also, involuntary weight loss, such as in cancer cachexia, causes a decrease in adipocyte size without a change in number. And cachexia is never allowed on the Times Spelling Bee. Neither is the other one. Okay, so cachexia, this is just Google AI, is a complex wasting syndrome characterized by unintentional weight loss, primarily of muscle and fat, and is often a complication of chronic diseases like cancer. Inanition is the other one I was thinking. Inanition. Never in the New York Times Spelling Bee, it is a word. The dictionary, Oxford Dictionary definition is exhaustion caused by lack of nourishment. Lack of mental or spiritual vigor or enthusiasm. So probably when I use the word inanition, I mean cachexia. But they're both just severe undereating. Inanition, you'll often see the word with reference to like elder abuse. Back to the article. Complementary studies looking at weight gain over several months show that significant weight gain in adulthood is associated with significant increases in adipocyte volume. But similar to weight loss, no net change in adipocyte number. And they spelled net wrong. N-E-T-T? Maybe not. I don't know. These results and others have promoted the view that weight change in adulthood is primarily the reason of changes in adipocyte volume. Given that in adulthood, adipocyte number stays constant and weight changes are predominantly accompanied by changes in adipocyte volume, one may conclude that at some critical point in development, the final fat cell number is attained, and after this point, no fat cell turnover occurs. Okay, so me talking, not the article. This is just not the way biology works, so there would still be, like, fat cell turnover. And again, I'm a molecular neuroscientist. Neurons are a very specific type of cell that do not regenerate. You do have turnover in some areas, but for the most part, don't huff chemicals because you'll screw up a system. Back to the article. Analysis of adipocyte turnover using carbon-14 dating, however, has recently shown that this is not the case, but rather that adipocytes are a dynamic and highly regulated population of cells. New adipocytes form constantly and replace lost adipocytes. That is how biology works, ladies and gentlemen. It's such that approximately every 8 years, 50% of adipocytes in human subcutaneous fat masses are replaced. And before I continue reading, if you're wondering, well, what happens to the old fat storage? I mean, there would be, based on what I know of biochemistry from 12 years of education and 15 years post-education, I would say that either there's excretion of that fat in, it's called exosomes, and other cells take it up. And then once the new cell is generated, that's going to then either reclaim some of that fat. It won't be like the same. It's not like NFT fat. Or it'll just become a new storage place. Alternately, the new cell could grow and then specifically take the fat from the old cell through either exosomes, or I could imagine a direct communication, and then the old cell would die. Because that's how stuff works in biology. It's very systematic. It's very repetitive. Okay, going back to the article. Adipocyte progenitor cells, also called pre-adipocytes, originating from stromovascular fraction of adult adipose tissue, can be stimulated to proliferate and differentiate into mature cells in vitro. Recently, white adipose tissue progenitor cells located in the perivascular compartment of white adipose tissue were identified in vivo and shown to be capable of reconstituting the adipocyte mass in lipodystrophic mice with significantly decreased fat mass. Necrotic and apoptotic adipocytes are also found in human white adipose tissue, even though no decrease in adipocyte number is seen with age. Together, these data suggest that pre-adipocytes are recruited to become lipid-filled mature adipocytes at the same rate that adipocytes die, and that in this way the fat mass is in constant flux. And the adipocyte number is kept constant, which that makes sense, and I think that's where the confusion comes in. So your relative number of fat cells is determined young, but those actual fat cells are not like maintained throughout life. There's turnover. Number 2, adipose cellularity and weight loss. White adipose tissue has been shown to produce a number of factors that act locally or centrally to regulate energy homeostasis and thus the fat mass. Some of these factors include circulating factors such as metabolites and hormones, as well as paracrine and autocrine factors such as IGF-1 and TNF-alpha. These factors and others, for example, sympathetic neural input has also been shown to regulate adipocyte proliferation, work in concert to maintain levels of adiposity. Recent studies show that TNF-alpha in human adipose tissue serves as an important regulator of fat cell and number in healthy subjects. For a complete review of all the factors regulating energy homeostasis, the reader is referred to reviews, and then 3 references are given. I will note that with IGF-1 and TNF-alpha, you have to be careful following those. They do a lot in the body, and if this were an area I would study, I would go and look up the source articles and make sure that they show negatives. Meaning, recent studies suggest that TNF-alpha in human adipose tissue serves as an important regulator of fat cell size and number. I don't doubt that they showed that, but did they also show something that did not do that? So did they use interleukin-2, let's just say? And interleukin-2 did not do this. And it's a common trend, especially in disease neuroscience. Let me drink some Diet Mountain Dew as I read this. Clear my throat. Pinnacle of health. It's common in disease neurosciences to just show positive things. So this does this without showing anything negative. This is very common with fibril forming abnormal proteins. So APP, alpha-synuclein, the APP does all this stuff. Physiologically, it probably doesn't act in that manner. It can do that stuff in the lab, but they don't show anything negative. So maybe if you just shake cells up with anything, you'll find the same thing that APP is supposedly doing. For example, so again, with this study, I don't doubt that TNF-alpha is functioning in this way, but what isn't functioning in this way? Can you show me a negative? And also, just with IGF-1 and TNF-alpha, they do a lot of stuff in the body, physiologically, not just in the lab. So anyway, doesn't surprise me to see them. Frequent flyers. On with the article. One well-characterized factor known to play a vital role in the regulation of body energy balance is the hormone leptin. Leptin is a hormone produced by adipocytes that functions both centrally and locally to alter the metabolic status to favor energy expenditure over energy storage. Circulating leptin levels are linked to adipocyte size, such that large adipocytes produce more leptin and small adipocytes. Increased levels of leptin then act on the brain, hypothalamus, to decrease food intake and increase energy expenditure. I pause because I'm wondering how they are defining energy expenditure. With the hypothalamus, and once you get into that area, you're also getting into higher brain functions, or what do I want to say? I'm not a morning person, and I'm filming this in the morning, only on my first Diet Mountain Dew. Pardon me. This is also why I don't make content, I guess. You're also dealing with a possible stimulation of, like, let's just say the anterior cingulate or even amygdaloid circuitry, but dealing with motivation, or in someone who has maybe anxiety or OCD personality disorder, not OCD. This increased energy expenditure can be physiological, but it can also be something that the person imposes, either due to an anxiety, I need to do this, or just a stimulation of, hey, I feel like getting up and doing the dishes, doing the laundry. Yeah, the hypothalamus, I wish, actually, is this going to be the anterior hypothalamus? I shouldn't get into this. Leptin, hypothalamus. I would guess it would go to both. I would have to look into this. I shouldn't have gone off on this tangent. Let's go back to the article. I got my PhD from a claw machine. Should have said that up front. In this way, circulating levels of leptin correspond to levels of correspond to levels of adiposity. Despite this, an attenuated response to leptin in the obese state has been observed. Right, which makes sense. Leptin availability to the brain decreases at high leptin concentrations due to a decrease in leptin transport across the blood-brain barrier, and leptin's ability to initiate cell signaling cascades within the brain also decreases. I believe with the hypothalamus, there is a, circumventricular zone, meaning no blood-brain barrier. So I don't know. Yeah, this isn't my area of expertise, obviously. And I did get my PhD from a claw machine. But I don't know leptin transport across the blood-brain barrier. The reason why I said obviously is you become desensitized to high levels of any hormone, any signaling, really. Same thing in life. If you eat ice cream every day, or say you go out and you get something that's really good and sweet, and it's so good and sweet the next day you go and get it. It might not taste as good that day. Or if it does taste as good, you get it the next day. At some point, it stops tasting as good because you are desensitized to it. And again, nature and biology are very systematic, very redundant, very repetitive. And a lot of times, these common things we observe in just the macro level, so our senses, are also how things work at smaller levels. And so it wouldn't surprise me that a hormone produced at a high level would start to be less effective, and there would be a feedback mechanism possibly so that it's no longer produced at as high a level. If I put on 60 pounds in a year, let's say I'll have increased leptin production, but if I maintain that higher 60-pound weight, like the leptin production, I can see it both being less effective, but also there being a feedback mechanism where it decreases. And I don't know any of this stuff. But I do know biochemistry and molecular biology, and that's how stuff works, generally. In contrast to going back to the article, in contrast to this, dramatically reduced levels or complete lack of leptin causes hyperphagia, reduced energy expenditure, and profound obesity in animals and humans. Leptin is just one of the many signaling events that occur in response to a decrease in adipocyte size, putting pressure on the fat cell via the brain to restore quote-unquote normal fat cell volume. Indeed, there is a very strong correlation between the size of fat cells and the production, as well as secretion of leptin in human adipose tissue. In addition to this, smaller adipocytes turn over triglycerides at a slower rate than large adipocytes, resulting in decreased energy expenditure of small adipocytes compared to large adipocytes, since triglyceride turnover is an energy-wasting process. Yeah, I was going to say, even before it mentioned an energy-wasting process, anytime you see something like smaller XYZ turnover triglycerides at a smaller rate than large, this is one of the reasons why lifespan is going to be shorter with too much calorie consumption and too much weight. I mean, the reasons are legion, but the body is just constantly working at a larger rate. And when you get into BMI talk and how I watch a lot of strongman stuff, and I do my own heavy lifting. While BMI is not accurate in terms of the amount of fat on a body, it is still accurate in terms of like just the work the body is doing. It's a great rough number to have with postmortem tissue is what I'm saying. So I work with brains, and most of the time I don't get BMI number, and that's a huge problem, especially if I'm doing like a CTE study, which is chronic traumatic encephalopathy, football players. I really want to know the BMI. But even if someone is at their peak physical performance, their BMI is high because they have a lot of muscle mass, your body is still working at a level that is not suitable for a super long life, if that makes sense. And here it's actually saying since triglyceride turnover is an energy wasting process. I mean, turnover of anything, it's your turnover means getting rid of old stuff, making new stuff. So, for example, protein turnover or neurotransmitter turnover just means that it's constantly being destroyed and remade, or new molecules remade. So it's the cell is doing work. Going back to the article, and I meant to just read this article without running my mouth. Back to the article. Thus, taken together, the lack of ability to lose adipocytes following significant weight loss, the increased fat-filling drive resulting from smaller adipocytes, and the decreased energy expenditure of smaller adipocytes compared to larger adipocytes may explain why the success rate in keeping weight off following significant weight loss in obese individuals is so poor. In parentheses, greater than 90% of individuals who lose weight on dietary or lifestyle regimes will regain the weight or more. Which, yeah, it makes sense. It also makes sense that it's the psychology of it. It's a lifelong habit. You eat, it feels good. And there's that saying, nothing tastes as good as skinny feels, but that's very much missing what psychology is. What if I can eat something sweet? I'm not a sweet person, but I mean, I mean that more ways than one. If I can eat something sweet and feel good, there's going to be that desire to do it. If I take meth and I feel good, there's going to be a desire to do it. And if I stop doing it for a while and then start again, all of that, the old patterns are going to come back in. So it's complicated. But it doesn't surprise me that there's a biological press also to get back to a certain weight. Anyways, number 3, back to the article, why adipose tissue cellularity. The fat mass in humans is the product of both adipocyte volume and adipocyte number. Objectively, obesity has been defined as having a body mass index of 30 or more, which is calculated by dividing weight in kilograms by height in meters squared. Obesity can be characterized into 2 main types: hyperplastic, which is increase in adipocyte number, and hypertrophic, which is increase in adipocyte volume. Obese and overweight individuals may exist anywhere along the cellularity scale. However, on average, certain trends appear. Hypertrophy to a degree is characteristic of all overweight and obese individuals. Hyperplasia, however, is correlated more strongly with obesity severity and is most marked in severe obese individuals. From this relationship, it is tempting to conclude that an individual increases his or her body fat mass, as an individual increases his or her body fat mass, so does his or her adipocyte number. Fat tissue cellularity data, however, has almost exclusively been collected cross-sectionally and therefore gives no direct information on what happens when an individual significantly increases his or her adult weight over a protracted period of time period. One cannot rule out that prolonged periods of weight gain in adulthood may result in an increase in adipocyte number. Indeed, animal studies suggest that increase in adipocyte size precede increases in adipocyte number, which is what you would expect. Or that's my saying, which is what you would accept. I've lost the ability to tell what is common knowledge and what isn't, so I'll just briefly comment that when they say data, however, has almost exclusively been collected cross-sectionally and therefore gives no direct information. Cross-sectionally means if you're comparing 2 ages, it's 2 different cohorts. So it would be a cohort of young adults, a cohort of middle-aged adults, versus following one population across time. It's very difficult to do longitudinal studies, both to get the funding and also attrition is high. So in part of my work with Alzheimer's disease and aging without cognitive impairment, we follow priests and nuns to death, and that has a low attrition. So that would be like a good population to do if you could get funding to do an obesity study. Not that priests and nuns are expected to be obese, but the attrition is lower, and attrition just means drop out over time, and people drop out for various reasons. Disease, moving, I think, would be the biggest one. You move away from a medical center and you don't bother. That's not high on a priority list, especially if you've been part of a study for 20 years of time. It's hard to understand your importance in that study. Also, there's, scientists die, new scientists come up, and it's hard to get funding for 20 years. If you got funding for 20 years to follow something like this, what's the guarantee that the, what's the word I'm looking for? Not prosperity, but the integrity of the research would stay the same over those 20 years. Okay, back to the article. Okay, this quote-unquote critical fat cell size hypothesis postulates that the achievement of a specific mean of fat cell size triggers a subsequent increase in fat cell number. And me speaking, not the article, I would hazard to bet that would be different per individual, and that's where genetics would definitely come into play. I would bet my bottom dollar. And my bottom dollar is very bottom, because I'm a scientist and scientists are poor. Buy me a coffee. No one's watching this. Whether and to what extent this occurs in humans is unknown, and long-term longitudinal studies are needed in order to assess this. So I don't know if I said it, but longitudinal would be the cross-sectional, longitudinal. Those would be the two types we're talking about. I think I said that. Therefore, at present, it is impossible to conclude whether the average increase in adipocyte number seen in obese and severely obese individuals is the result of adult adipocyte recruitment, or rather a reflection of a population of people predisposed, in parentheses, by their pre-adulthood fat cell number, in parentheses, to become obese or severely obese. In support of the latter, short-term studies in adult humans do not show any increase in adipocyte number following significant weight gain. In addition, hyperplastic obesity is often linked to early onset obesity. It is during this period fat cell number increases, and the extent to which this occurs is strongly linked to adult fat cell number. I want to add too that while I say that whether you increase fat cell number is probably a high, that I would bet my bottom dollar that's going to be a genetic influence, it does not surprise me, this, again, reading from the article, rereading what I just read, short-term studies in adult humans do not show any increase in adipocyte number following significant weight gain. That does not surprise me at all, because weight gain and weight loss, like these fluctuations, are a normal part of life. I guess living in a developed country where you have constant access to food, it's not. But if you look at any mammalian species, I don't know much about others, putting on weight is not like I wouldn't expect it to cause a switch into increasing fat cell number. Because the idea is that you're then going to use that weight either through caloric deficit or through increased activity at some point in the, well, I'm going to say the near future. So again, going back to, if I put on 60 pounds in a year, the overall physiological system would expect, which anthropomorphizing, which I hate to do, but would expect that 60 pounds would be used over the next year either through a caloric deficit or increased activity. So there would be no need to change how fat storage is done. If I'm on a regular basis, if I'm if I eat a high-fat meal, and I usually eat lean, I don't, then I would increase fat storage. There would be no reason to change that over a period of, let's say, a year, which I would consider short-term. But here, their short-term studies might be a few months, probably. Following someone for a year is kind of a long time in science. But going back to the article. Irrespective of whether man can acquire additional fat cells in adulthood, it is clear that fat cell number does not decrease in adulthood, even following long-term weight loss. So just my note again, because if you're watching at this point, you have gotten used to me interrupting myself. That's an interesting point that you don't often think about, or you don't often hear talked about with skin removal. A lot of it is cosmetic, of course, 100% fine, and also just pain associated with that excess skin. But it's also, you do have to get rid of, or you don't have to get rid of, but it's conducive to maintaining long-term weight loss to get rid of those extra fat cells, according to what we're presented with in this article. And according to common sense. Going back to the article, in line with this, hyperplastic obese individuals have poorer treatment outcome following diet-induced weight loss than hypertrophic individuals when controlled for fat mass. I'm gonna go and look up those again. Okay, hyperplastic is increase in adipocyte number. Hypertrophic is increase in adipocyte volume. Which, okay, yeah, plastic, like neoplasm, this is a tumor with lots of cells. Trophic means growth, or I mean not growth, it means I need to find it on my website. Let me just do that. Well, I'll do that. No. You know, if only cameras had a pause button, right? So I wouldn't have to drag you guys through this. But I did recently do the direct translation. And I did not upload this. Anyways. Because there's trophic and tropic. Trophic, let me do it this way. Meaning food or nourishment. Which, often growth, or in science it's used, yeah. Okay, anyways, my brain went off on a tangent. Inside. Where was I? I'm gonna start that paragraph again. Irrespective of whether man can acquire additional fat cells in adulthood, it is clear that fat cell number does not decrease in adulthood, even following long-term weight loss. In line with this, hyperplastic obese individuals have poorer treatment outcome following diet-induced weight loss than hypertrophic individuals. Meaning people with lower fat cells are less likely to maintain, or this is me speaking, meaning that obese individuals with that increase in number of fat cells. Then again, how do they know? I wonder if this is knowing that they increase the number. I bet this is just number per volume. So if you take a section, or if you, like from people who have had surgery, if you analyze that, mass that you see removed, if there's an increased number per volume compared to, let's assume the person lost weight. So compared to their size and... I guess BMI would work here. Their size and BMI when they were at their largest. I bet you that's where the hyperplastic versus hypertrophic is coming in, is just the density, so volume of cells per what would have been like a square, meter. Not a square meter. Square millimeter in the pre-weight loss condition. Because again, they don't have longitudinal data, right? In line with this, hypertrophic obese individuals have poor treatment outcome following diet-induced weight loss than hypertrophic individuals, in parentheses, when controlled for fat mass. Often for hyperplastic obese individuals, treatments other than diet and exercise are necessary if substantial and permanent weight loss is to be achieved. Successful but invasive therapies include surgery to reduce the amount of calories ingested, such as gastric bypass and/or surgical removal of fat tissue, for example, reconstructive surgery or liposuction. The recent discovery of high turnover of adipocytes in adult human white adipose tissue, approximately 10% annually, now establishes an additional therapeutic target for the pharmacological intervention of obesity. Understanding the mechanisms that control adipocyte turnover in vivo may lead to interventions that affect the adipocyte birth-death balance so as to achieve changes in body fat mass. So, me speaking, this would mean theoretically that you could decrease the number of fat cells by by targeted stopping of turnover, thereby preventing a person to need to have an invasive procedure such as surgery, or even here the gastric bypass. And that would be in someone who is actively trying to lose weight, not just. I mean, I guess I'm not a pharmaceutical magnate. I would argue you would only want to do that in someone who has demonstrated an ability to maintain a regimen. Sorry, not a regime. No one started any regimes. A regimen. Going back to the article, adipocyte turnover is not only important for regulating the total fat mass, but also for the morphology of human adipose tissue. Using the carbon-14 dating method, we recently found that adipocyte turnover is important for the development of hyperplasia and hypertrophy. Decreased adipogenesis adipogenesis and relative adipocyte death rate were demonstrated in hypertrophic compared to hyperplastic individuals. Furthermore, there was a strong correlation between adipose morphology and total fat cell number in the body. Subjects with hypertrophy have a significantly lower number of adipocytes than those with hyperplasia, independent of the total fat mass. The morphology of adipose tissue has a clear clinical relevance. In a large population-based sample, hypertrophy was associated with decreased insulin sensitivity, even in lean and apparently healthy subjects. In addition, adipose hypertrophy might be diabetogenic, with 2 independent prospective studies showing that adipose hypertrophy is an independent risk factor for developing type 2 diabetes. And then my note, when it comes to insulin sensitivity and insulin resistance, that's like a whole area of science. And it's not as simple as people who react to fat activism or that, what's it called? Oh, my brain is thinking science, can't think TikTok and crap. Fat acceptance. People who react to that stuff, and people in the fat acceptance movement, people living in a larger body, tend to very much simplify insulin sensitivity or insulin resistance. It's a whole fucking science. Back to the article, number 4, tipping, by that, well, before I go back, let me interrupt myself again. What I mean by it's a whole fucking science is there's a lot of factors at play. It's not just simply eating a lot of sugar consistently. There's a whole lot of intermediate factors. Okay, back to the article. Number 4, tipping the birth-death balance, ? Tipping the birth-death balance? Cell death of fat cells in white adipose tissue occurs primarily by necrosis-like cell death. Unlike apoptotic cell death, where cells die in a controlled, non-inflammatory manner, necrosis and necrosis-like cell death, involves macrophage recruitment and a subsequent inflammatory response. Necrosis-like cell death and associated macrophage recruitment activation is increased in individuals with increased adipocyte size and body mass index and has been implicated in the metabolic complications of obesity. Wilt studies in vitro have identified a number of factors that appear to regulate adipocyte death and pre-adipocyte proliferation and differentiation. For example, resveratrol has recently been shown to induce adipocyte death and inhibit adipogenesis in a fat cell line. Very little is known about the in vivo situation in humans. Additional studies are needed to determine if decreasing the fat mass by increasing adipocyte death stimulates an inflammatory response resulting in a worsened state of health. Whether the brain-body responds to adipocyte death by increasing pre-adipocyte proliferation and or differentiation in an attempt to maintain the fat mass is unknown. An additional point to take into account when looking at adjusting adipocyte birth and or death rates is adipocyte tissue cellularity. Many of the metabolic complications associated with obesity are directly related to adipocyte volume. When controlled for fat mass, hypertrophic individuals have a worse metabolic profile than hypercellular individuals. If one decreases his or her fat mass by increasing adipocyte death and or decreasing adipocyte production with no subsequent change in diet or exercise, existing adipocytes will be forced to take on the extra lipid. That's what we've been wondering about with Ms. O'Brien. The resulting increase, or that's what we've been hypothesizing will happen. The resulting increase in average adipocyte volume will increase the individual's likelihood of developing metabolic disease. One scenario where manipulating the birth-death balance could be of therapeutic interest would be cases where hyperplastic obese individuals have successfully decreased their fat cell mass by decreasing adipocyte volume. However, they are limited in achieving further weight loss or maintaining their weight loss due to having excess number of adipocytes. So that was what I said. It would be an alternative to having an invasive surgery, and it potentially more expensive. Tipping the balance in favor of reducing the number of fat cells in parallel with diet and exercise could reset the individual's fat mass to a healthier level. Makes sense? Number 5, conclusions. Obesity is a condition characterized by having an excess of fat cells, which are increased in size relative to lean individuals. Traditional weight loss regimes is used. Regimen. Huh. Words, everybody. Traditional weight loss regimes, such as diet and exercise, are successful in decreasing adipocyte size, but fail to reduce adipocyte numbers. Since many obese and almost all severely obese individuals have more than the average number of adipocytes, methods other than diet and exercise alone are needed if one hopes to reduce and maintain the fat mass to lean levels. They use regimes, but I think it's supposed to be regimens. I'll explain in a second. The dynamic and highly regulated turnover of adipocytes in adult humans establishes a new therapeutic target whereby pharmacological intervention may potentially tip the balance in favor of weight loss or gain, depending on the preferred outcome. Okay, that's the article called Fat Cell Turnover in Humans by Peter Arner and Christy L. Spalding, Spalding. Arner is Arner, published May 2010 in the journal Biochemical and Biophysical Research Communications. So my doctoral work was on a nutrition intervention for a neurological condition. And I was always very careful between the words regime and regimen. Yeah, so regime is a government, especially an authoritarian one. And then it can also be a system or plan way of doing things, especially one imposed from above. So I was always very careful to say regimen. I believe, like dietary regimen. Yeah, regimen is a prescribed course of medical treatment, a way of life, or a diet for the promotion of restoration of health. And then it used to also mean, archaically, a system of government. Yeah, when I was writing my dissertation, I would constantly double check that. I'm trying to say, what's like a World War II regime. So there was another article I was interested in that I pulled up, and it's called, that's a little different actually. It's the changing color of fat. So there's brown fat in babies and then white fat. And this also talks about hypertrophy and obesity. I might read that. I don't know if anyone will watch this. Bye.